We are with our last but not least disruptor, because I don't know, could you tell we have made it to the disrupting phase of our conference? Dr. Abiola Ibraheem of Aortic and the University of Illinois, Chicago, and she is redefining what clinical equity looks like in practice. Her work bridges continents from research labs to patient wards and challenging systems to deliver care that is both evidence-based and just for the patients. And stay tuned because we have her for Q&A.
Hello, everyone. Good day, good morning, good afternoon, good evening, wherever you are in the world. My name is Abiola Falilat Ibraheem, and I'm a medical oncologist at University of Illinois at Chicago. Today, I am honored to be one of the speakers on the Global Colorectal Cancer Congress, where I will be speaking on the unseen crisis as far as colon cancer is in Africa. So the title of today's topic or talk is The Unseen Crisis, Colon Cancer's Devastating Toll on Africa. So this is the outline of our talk. First of all, I will start this talk with personal storytelling, and we'll go on to talk about the colon cancer burden, colon cancer screening, and cancer clinical trials in Africa. So, my personal experience with colon cancer, where I was the other side of the aisle, my mom, she's not my birth mom, but my birth mom died when I was 10, so she adopted us. So that in the developed world you call that your aunt, but in Africa that's your mother, right? Or your big mommy, and then we call big mommy depending on where you live. She's big mommy to first to a lot of people, but to me she's mom. And sometime in 2017, we were planning for her 70th birthday, which was going to be on July 29th, 2018. But months before that, she was always complaining of this vague abdominal pain and had been persistently anemic. She was being seen by one of the top most private hospitals in Lagos. And every time she went, she was given blood tonics, vitamins, she was treated for malaria. And as the months passed, her symptoms continued to worsen, and she moved on to another hospital with the same diagnosis and what have you, until January 2018, when she had constipation. At that point, which is almost a year, when she was showing up in a hospital of discomfort, but she didn't really lose weight. Someone did a CT scan, and she did have obstruction. She had a colon obstruction, and then they found out there was dilation of a transverse colon. And at that moment, when I got her CT scan, we were trying to navigate the healthcare system. It was a very brutal experience for me. Then I moved from being a physician or a healthcare provider to being a family of a patient. And within the 3 days when we were trying to navigate the healthcare system, she died. So that made me understand that how fragmented the healthcare system, how much problem that we had, until it happens to you on a personal level. Of course, this is an AI-generated picture of a woman because, again, because of the cancer stigmatization, and I won't want to offend anyone, which is why her personal picture is not on display. So there is a growing burden of colorectal cancer in Africa as it is. Globally, is the third most common cancer worldwide and the second leading cause of cancer-related deaths globally. And Africa is experiencing a rising concern with colorectal cancer. Across the continent, we see a rise in incidence. it's worse in North Africa. And the factors with which we are having this rising incidence of colorectal cancer has been due to the urbanization or westernization of African people, right? We are much more westernized, the social media, what we eat, our lifestyle, our BMI is much, much higher. And I always used to say this, whereby when we were growing up, we had a family friend who we all looked at being obese. We always thought he was obese as a child. But then when we saw the pictures we took when we were very young, we saw that we were the malnourished one. He was actually the normal kid, but because we were all malnourished, he was obese to us. But things have changed now, where you see kids that are obese or morbidly obese, and that's because there's so many fast food restaurants everywhere in Africa. People don't walk as they used to walk. There's no activity as we used to have. Everybody is on their phones, on their social media. Back in the day, everybody went out. We all did, there was always a communal distance. But now we don't have that because we're now westernized. So with that shift in our lifestyle, we have seen that there's a exponential rise in colorectal cancer, in cancers, especially colorectal cancer. In addition to that, we know that there is a genetic predisposition to that because patients with colorectal cancer are more likely to be young in Africa, and when they're present, they have these hereditary cancer syndromes, and they're more likely to have microsatellite instability. So when you look at the survival and mortality rate, it's a stark contrast, whereby we still do agree that the incidence of colorectal cancer is higher in high-income countries, for sure. But then the mortality is higher in Africa. So the mortality ratio, index ratio is much, much higher in Africa. So we know that when a patient does have colorectal cancer, even if they present early, they are more likely to die from that disease compared to patients that present in high-income countries. This is because most African countries lack comprehensive cancer registries, and we don't even know what the extent of the burden. But we do know that even the little times when we can capture the incidence, there's a high incidence. But then we are yet to determine what the true burden of disease is. So, what are the barriers to effective colorectal screening in Africa? Of course, we know that there is few people can actually do endoscopy in the country or in the continent, and those people that are trained that can do trained colonoscopy, that are trained in being able to perform colonoscopy, they're not really much. And when they're able to do that, you see them in the private sector, and it's really expensive. And there is poor public and health care provider knowledge about colorectal cancer symptoms, like my mom, who was showing up to the hospital, and it took the doctor many months and her almost dying before he even thought about, let me do a CT scan. So even when the patients show up, the doctors have no clue, and that's because the healthcare providers have been oversensitized with infectious disease and other diseases, that when colorectal cancer shows up, it's masked with other diseases. And then we have a lot of cultural barriers, whereby there's social, demographic, and cultural factors that hinder the screening participation and uptake of colonoscopy or screening, colon cancer screening. And of course, there's competing priorities in an environment where majority of the people live on less than $1 a day. They of course have competing priorities like feeding, clothing, shelter, education, just lifestyle, or even in the healthcare system, we have competing priorities like infectious disease, communicable disease, HIV, AIDS, tuberculosis, and then the brain drain. So I will go on to talk about screening strategies. So to be able to address this colorectal cancer burden, we have to start thinking about healthcare provider training. Like I said, I initially trained in Nigeria. Before I came here, I trained in Nigeria, and I worked in Nigeria for 6 years before I moved here within the public and the private sector. But what I will tell you is that by the time I finished my medical school training, I was well vast in infectious disease. I could take an infectious disease board, and training or training as far as cancer classes or oncology courses was so minimal. It was so, but it was more of infectious disease, infectious disease, infectious disease. So we might want to start looking at our medical student curriculum or healthcare provider curriculum. People that are practicing physicians, especially the primary care physicians, have to be retrained to look out for this kind of diseases. And of course, nurses have to be included in this training. The community health workers, who are the people that are going to be seeing majority of our patients in the community, have to be trained for this. So they are cost-effective testing before you get a colonoscopy, especially when we have majority of patients. We can start thinking about deploying the non-invasive fecal immunochemical testing, the FIT, to be able to actually increase screening accessibility and affordability. But this also has its own shortcomings, which is patients that are heavily infested with parasitic infection might have false results. And then we know that we have to start adapting the screening protocols in a high-income country to actually determine, create a paradigm with which we are able to narrow down the people we're going to be screening and start thinking about, some people who are more prone to have early age onset colorectal cancer may actually get screening earlier. And then opportunity screening, especially when patients show up in the hospital for something else, we can get them screened, even if it's just taking a history or just doing a digital retinal exam with them, or an FOBT, or partnering with religious houses like churches or mosques to be able to catch those patients from the healthy population. And policy and investment. We need political will to actually identify that this is an issue and to be able to create interventions for us to be able to address this. So as far as treatment is concerned, the current treatment landscape in colorectal cancer faces significant hurdles. We know that most of our patients are more likely to present late. And even when they present early, surgery remains the primary curative options that they have. And we really have not much surgeons that are really trained surgical oncologists or even trained colorectal surgical oncologists whose only specialty is colorectal cancer, because most of them are general surgeons. And then the access to modern chemotherapy, targeted therapy, immunotherapy, radiotherapy facilities is restricted or sometimes out of reach, or to most patients in that environment. And the facilities that have this things like the chemotherapy, immunotherapy, targeted therapies are in major centers, meaning that less than 10% of the population will even have an access to get into these places. So what about research and clinical trial? And we know that as far as colorectal clinical trials in Africa, it's still in its infancy stage. Africa has been largely excluded from global cancer clinical trials, especially early phase colorectal studies. It's always very interesting when you look at all those FDA-approved therapies or technologies, and it's how it's globally conducted, and they have this huge map. And when you look at the map with which this was conducted, Africa is omitted. And even if they conduct these trials in Africa, they're more likely to do it probably in Egypt and South Africa. And most of the patients that participate in those trials are white patients, again, which makes it, we go back to the lack of diversity in our clinical trials. So African Organization for Research and Training, that is AORTIC, it's an African organization, a huge organization, a Pan-African organization with which I am the vice president. And we have identified key strengths that position Africa for greater trial participation. And one of the things we do understand is that through clinical trials, Africa can actually have a stake in the game. Clinical trial participation can provide patients with access to cutting-edge therapies that are normally unavailable through standard of care. And we know that through clinical trials, the healthcare system can be improved. I know that in firsthand because I've been investigator to some trials that once we started the trial within the institution, it addressed the fragmentation of that institution, and it actually made the healthcare system within that institution patient-centered. We have a proven track record on the African continent. We have been successful in conducting infectious disease clinical trials like HIV/AIDS, TB, and have truly demonstrated Africans' capability for rigorous research. The AORIC has also identified key strengths that position Africa for greater trial participation. Through the AORIC, we have partnered with many organizations and have trained over the decades multiple local clinical trialists and research professionals within the continent. We have established research consortia and networks within the continent, and there is growing political will. So because some ministries of health have recognized that and are beginning to make it easier for people to be able to conduct clinical trials within the continent and within countries. We have robust ethical framework, scientific reviews, and regulatory system. And there's this development where you can actually get ethical approval and at the same time be working with regulatory systems side by side in parallel. So what are the challenges in conducting clinical trials, cancer trials in Africa? And one of the major challenges has been resource constraint. And there has been barriers to funding, or even the question is, what is the standard of care? Is the standard of care applicable to those parts of the world? And can the patients afford this? Then the lack of inadequate fracture infrastructures, the lack of cold chain supply, concerns about data quality or reliability or integrity has been ongoing. But then again, there's so many activity that's being done within the continent to address this. And we have, there is a critical requirement for enhanced training of research assistant, regulatory compliance, research administrators, or the administrating team as it is. And as far as ethical consent consideration, there's a huge concern about ensuring post-trial medication access, guaranteeing that research benefits reach local communities and population. And then we are able to, the other major problem has been logistic hurdles, the concerns about patients being lost to follow-up, consistent data collection, and maintaining research continuity. So we have to seize this moment for Africans' fight for against colorectal cancer. There is a rising burden of colorectal cancer across Africa, and this demands an urgent coordinated action between screening programs and pairing it with clinical research initiatives. Of course, treatment is important, but then we do know that especially treatments that are life-saving could be out of reach. Perhaps through clinical trials or research initiatives, this might be reachable to our patients on the African continent. Africa is uniquely placed because of a distinctive genetic and epidemiological profile, where we can offer invaluable insights for global cancer control strategies. And then we can actually transform what we have now by expanding the clinical screening and clinical trials to transform the outcomes and of our patients. We can actually achieve equity through cancer delivery if we can actually expand the screening and clinical trials that we have on the continent. I hope with this presentation, we have to understand that we have to reach out to our policymakers and support for there to be political will, secure funding, and build collaboration that would empower Africa to lead in colorectal prevention and treatment. While I thank you for listening, I want to make a personal plea because this is deep for me. And every time I think about colorectal cancer, I remember my mother. I remember my mother who has been dead now for almost, this is 2025, almost 7 years. And I put this AI picture of cultural aware because this was something we had from discussing about her daily, what she was wearing with the beads and how colorful and putting things together. We had to change the catering per people that were going to cater for her 70th to cater for her burial. And it was so devastating. And the loss of loved ones to this preventable disease, to this actionable disease resonates deeply in our lives and our families. And from where I sit, I know that the only reason why she's dead today was just because of a geographical location. And I hope that in my lifetime, the survival of a patient, the outcome of a patient would not be directly related to that geographical location. Colorectal cancer is reaching and touching lives, families, and it has a profound personal strategy that impacts the very fabric of our society. Thank you all for listening. Thank you for inviting me again to the team that has been working with me to be able to create this talk. I am available for any questions and suggestions. Thank you.
Hi, everyone. We're back, and I am so excited that we were able to have Dr. Ibraheem live for a Q&A. Dr. Ibraheem, are you with us? Hi.
Hi, how are you?
I am good. Thank you so much for joining us and for such a great presentation that you have given. And so I'll start with the first question while we wait to see if there are questions that pop up in the chat. And so first, I want to thank you for sharing your personal story, the personal why regarding your mom and your mother. And so I just want to ask, how did your experience change how you see the connection between data dignity and the human cost of delayed diagnosis?
Until it happens to you, we can always talk about the fragmentation of the healthcare system. And after that experience, in Chicago here, I made it a point that my healthcare system and where I get my healthcare is not the bougie hospitals. I go into the hospital of the community. So I have firsthand experience on the delays, and I write letters and I make calls because, it's easy for us as doctors or physicians to know the better healthcare system, if you will. I go to the healthcare system that serve community like myself.
That was definitely amazing. And thank you again for sharing that. And when we talk about data in global health, it's often clinical and technical. But for communities that have been overlooked or misrepresented, how can data itself become a form of justice and empowerment?
So I think at the end of the day, when we talk about data in all levels, as far as incidents and even in research, we have to get a seat at the table. When I talk about community, I will focus on the minority communities because these are the communities that are often overlooked and probably because they are competent factors. So I think that our community centers, our healthcare centers have to actually have their data represented. And when you present in a hospital or in a clinic, we have to start thinking about how do we get the biopsy of when we collect microbiome or when we are collecting epidemiology data, right? We have to go to the community and make sure that it's represented. And I'm of the opinion that at some point, very soon, we have to also ask for representation in all those genes that are being collected or all these genomes that are being collected, risk factors, data that are being collected to ask if it's truly representing our communities. Because if we ask that, then they will be forced to go into that community to make sure that those data is being collected.
Can you briefly talk about the work that you do by bringing clinical trials into, oh, wait a minute, I have a question for you. All right, let's see here. Okay, so the first question I have from the audience is, do you have any tips on recruitment of groups who are marginalized and have poor experiences from their home country?
So if I'm talking about recruitment as far as clinical trials is concerned.
Well, they didn't say so. If the attendee who asked the questions, we're going to assume that they're talking about clinical trials, but yes, yes, she said yes, anytime.
So the thing is, we are trying to put in programs in place. The thing is always awareness and perception and also knowledge, right? And addressing the healthcare literacy. And the truth of the matter is that we in the science world, academics, we are more reactive, right, and not proactive. You know, we react to when there's a problem or when there's a catastrophe before we start involving the community. So one of the focus of my research is developing culturally adapted videos and taking it to African countries and talking about clinical trials and the science and partnering with the churches to be able to discuss this as an intervention. Because we know that all those targeted therapies might not be available to us in country or even in the community, but we do know that the involvement of things like trials can actually help get these innovative therapies available.
And so I have another question from our audience member. Says, I'm a stage 4C thriver from Nigeria. The basic problems here is accessing quality and improved cancer care, and also cost implications, because we fund our treatments here and on the high side, and it's on the high side, especially we that are on targeted therapies. So I'm not sure. Maybe that was a
I
statement.
understand the question.
Okay, gotcha. All right, thank you.
I mean, I think I have the privilege of having practice in Nigeria, and I understand what her question is. So I will just quickly give a quick background for that because for everyone else to understand. Most cancer patients in Nigeria, they pay out of pocket. Even the ones that are on insurance before they have cancer, most insurance, I don't know if any insurance covers for cancer diagnosis. Once there's a cancer diagnosis, you're on your own. And I've seen patients who go as far back out as selling their houses to try to get therapies. And it's very, very expensive assessing quality care. The private hospitals that do offer this is too expensive, and sometimes it's out of reach. And sometimes they have to go to India, they have to go to other parts of the world. The cost of traveling and all that, again, it doesn't even add to the quality of their life or their outcome. So now the question now is, what are we going to do? You know, even on medical tourism, the amount of money that Africa spends on medical tourism, the loss of their brain, which is healthcare workers or the patients running out of the continent, it's over $40 billion. So we actually did, I started this, I don't know if you know ASCO, that is the American Society of Clinical Oncology. So I took the best of ASCO in Africa, best of ASCO Africa to Ethiopia. And through that Best of ASCO Africa Ethiopia, we discussed the innovative therapies in 5 major cancer types. And we were able to develop an initiative called the African Access Initiative. And through that initiative, we were able to get pharmaceutical industry involved, political makers involved, and policy makers involved to start discussing how do we get these innovative therapies in Africa. We cannot wait 10, 15 years before when drugs get approved in the United States for it to get to Africa. So we have the next upcoming conference that is going to be in Nigeria, Abuja, Nigeria, where it's also Best of ASCO, but the theme again is going to be Africans' access to innovative therapies and technology. So these are the things whereby my summary, we are chewing gum and running at the same time, and we understand that people like my mom, it should never happen. So she should have the access to therapies. Our patients are actually presenting. You know, back in the day, we said the patients don't come to the hospitals. Now they come to the hospitals. Now they show up. And then it means that the healthcare system has to be tightened, and we have to know what we are doing to be able to address the problems that they are bringing in, and also to bridge that barrier so that there should be global cancer equity. Even in the United States, even in Chicago here, you go to some parts of Chicago, Chicago, they have everything. You go to other parts of Chicago, there's almost nothing. So there has to be equity globally. There also has to be equity nationally.
Yes, and thank you so much, because that answer was full on, very informative, but so on point. And thank you so much. And so we have one last question for you. And so it's a comment and a question. It says, amazing presentation. I'm Loretto from South Africa. How do we support this work of early screening for colorectal cancer? I'm not in the medical field. However, I have a vested interest in supporting clinical trials, getting data, and making sure we support those in need without being reactive. Where should I be looking to have a seat at the table?
Thank you for that. My email, please share my email. And that's because we need people in the community, people in Africa, people that are religious to actually have a seat on the table. And I know that we are having a war on information. There's a war on science. There's a war on doctors. There's a war. And I'm not surprised at this, because I will say this, that unless you start talking to the community, there will be the distrust in this healthcare system always. And the first question, which is early screening in colorectal cancer, we are far away from that, but we are still working towards that, because then there are a lot of competing issues, right? There's a lot of competing issues where people need to feed, the cost of living is getting exorbitant, and then talking to them about screening is something that I'm not sure that Africa is there yet, unless, we have some countries in Africa that actually might be ready. But things like FIT testing, which is cheap, or FOBT, which is cheap, and history taking should be actually taught to nurses, community workers, and doctors, so that even as basic as that, then we can narrow down the people that needs to quickly get colonoscopy. And the colonoscopy should be almost free, because the cost of what it is right now, it's ridiculous. And then as far as the clinical trial part of it, one of the strategy we are using is, for me, is getting the community and the religious homes to be part of it. And every time I tell, especially the Christians, I tell them that, well, the first clinical trial ever recorded in the world was actually in the Bible, in the book of Daniel, right? So, right, yeah, I can see you're like, oh, yeah, it is. So where Daniel said to the Enoch that, listen, I don't want to eat the food from the king. I want to eat vegetables and water. Give me that for 10 days. That is sample size, N of 4. Him and his 3 of his friends, N of 4, 10 days duration of time. And then overall, they looked at the outcome. The outcome was he looked better than the other people that were eating wine. And the funny thing is, in the world of today, when you eat meat and you eat wine versus someone that eats vegetable and water, those ones look better, right? So if that is where the science started from, why is there an attack on science, right? So this is where we have to actually take charge. We Black people, we are very religious. Africa is a very religious continent. We should have a seat at the table, and we should actually take clinical trials as ours. So I cannot do this without the help of community. I cannot do this without the help of patient advocates, because the louder the voice, the more the political will be moved towards that direction.
Wow. That was an amazing answer. And thank you. Thank you so much. So I want to thank you not only for your science, but thank you for your courage and making the invisible visible, and sharing your personal why you do this work. And I'm so happy that we were able to do this Q&A, and I hope everyone else, really, gleaned from this. And we will be sure to share your email address in our email that we're going to send to everyone, and hope that you get a lot of responses back. And so you reminded us that disruption in global health isn't just technological, it's moral. It's about refusing to accept that a person's outcome should depend on their postcode, right, or zip code, and where they live, and that data should not sit in someone's database. Thank you so much for taking time today. I so appreciate you, and thank you so much for your presentation, and I hope that everyone else did.
Thank you for having me. Thank you for having me.
Thank you.
Bye-bye.
Bye-bye.